All right, so this is going to be the June 2023 MEC Minute, and the topic for this month is going to be a calm, casual, laid-back review of our heads-up CPR process. And I really doing this just to reinforce what we discussed last month and to make sure that everybody is getting up to speed and ready. I'd also like to uh, review some of the questions that I've heard as I made my way around the stations regarding the new heads up protocol and the termination resuscitation protocol as well. So, again, using some of the slides and some of this is redundant. What does it involve? Keep in mind we have to have our physical therapy wedge available. You, as an agency, will have to decide where you're going to store it and how you're going to store it. Are you going to store it with the tarp that's part of the process, or are you going to keep it somewhere else? Is it going to be on the engine, or is it going to be on the medic? I know space can be tight, but I think where you store this device is local. You figure it out. As part of this process, we are going to need one or two sets of defibrillation pads. Just as a reminder, we'll need that second set of pads if the patient's in VF arrest. So as part of our process, we're going to get those pads underneath the patient, or at least that one pad behind the patient as part of the second set. We also need the Lucas as part of this, so it's impossible to provide adequate CPR with a patient who is on a cushion or a pillow or a bed mattress. Those things will absorb all your compressive energy. And there's a recent article published that showed that CPR in a bed without a backboard reduces your compression abilities by about 30 to 50%. So we need to have something stiff behind the patient, which means the back plate of the Lucas. And then we also, as part of our process, have that tarp and mega mover. And we also have added the rescue pod, which is a device that goes inline in the airway system, so it can be there to provide or increase the amount of negative intrathoracic pressure as we come off the patient's chest during CPR. So the rescue pod should be placed as probably the last thing before the bag. So you have your endotracheal tube or your iGel, then you have your capnography sensor, then you have the rescue pod, then you have the bag. So these are the things that you need. Hopefully everything's available and in your station by now, and you should be practicing on how these things are applied. Quickly in review, what does our process involve? Well, again, our heads-up CPR process is for patients who suffer an atraumatic cardiac arrest. It does not apply to children, so this is for adults. It does not apply to patients who are suffering cardiac arrest from acute trauma. The patient also has to fit the Lucas. So if you have a patient that's too big or too small to be adequately fit within the Lucas, then they are not a candidate for this process. It's standard CPR, patient flat, no wedge, just good cardiac compressions done manually. Also, as part of our process, we're going to provide stabilizing therapy and allow the scene to stabilize for the first 2 to 4 minutes. This is one of those questions that have been asked. Why are we doing 2 minutes, 3 minutes, or 4 minutes? Well, really, what we want to do is our priorities don't change. We arrive on scene. Our first priorities are scene safety, followed by good cardiac compressions and defibrillation if indicated. We're going to get the patient's head elevated with the wedge, get the Lucas in place when we have adequate resources on scene to assist us in doing this. So, it could be 2 minutes, it could be 4 minutes. From my perspective, it's going to take at least 2 minutes for things to settle down well enough for you to get this device positioned. Also, as part of our protocol change, all of our defibrillatory shocks will be at 360 or 200 joules if you use the Zoll. We're not doing any stacked shocks. We've also added vector change after our third standard shock. So if you have a patient who's in VT or VF that requires defibrillation, we're going to hit them with 3 standard shocks at 360 with the traditional pad placement. If the patient remains in VF or VT, we are then going to use the anterior posterior pads to deliver additional energy. On the next slide, I'll again review pad placement. So, 3 standard shocks at 360 or 200, depending on your device. Patient remains in a shockable rhythm. You're going to then switch over to the second set of pads, and we're going to shock them with the same energy level, but with the second set of pads. Yeah, we did change our TOR policy to 30 minutes on scene. for PA or asystolic arrest unless there are extenuating circumstances. These are a common question I received as I made my way around the stations in the past month. I'll cover this in more detail later in this discussion. But studies definitely show that if you are worked on scene, your chance of survival doubles than if you're worked in the back of a moving truck screaming on the way to the hospital. And then we're going to transport patients immediately if they have ROSC or if they've had 5 shocks and they're still in VF. Shockable rhythm that is sustained and we cannot abort with shocks, those patients are not 30 minutes stay and play. Those are 5 shocks, load up and go. There may be some additional interventions at the receiving hospital that could provide benefit to the patient. Just a quick review of our pad placement. This may take some practice. I know I try to do this, and if you watch the video from last month, you'll see it's an easy concept, but you got to make sure you know where your pads are going. You need to know how big they are so that they don't touch when you put them in place. The second set in place, you also have to be aware that the second set of pads should not directly go over a pacemaker or AICD. So if you look at the picture on the left, that's our standard placement. We have one pad goes to the right upper pectoral area, and the left pad goes to the mid-clavicular to mid-axillary line at about the level of the 6th rib, so generally below the nipple on patients. That's our traditional placement. If we have a patient with a shockable rhythm, we shock them, and they are still in a shockable rhythm. We don't get them back into sinus. We are implementing our heads-up process as part of our placement of the wedge. We need to sit the patient up, and as we sit the patient up, somebody needs to put that second pad behind the patient between the lower scapula and the spine. So it's the left posterior shoulder. So that's the pad that would traditionally go to the right anterior chest. The second pad as part of our vector change is the same pad that you would put in the left lateral chest. This second pad goes above the first pad in a vertical arrangement. Again, it does not sit on top of or does not get placed on top of an AICD or a pacemaker, and the 2 pads on the left chest should not be in contact with each other, because if you discharge one of the pads, you may get a short and you may end up burning the patient. So this is just a quick review. I think it will take some practice because if we sit the patient up to put the second pad on the back, somebody needs to be well rehearsed. They need to be able to identify the landmarks and quickly get that pad in place before the patient's put back down onto the wedge. So that's kind of my quick review of the process. So some of the questions I've heard regarding heads up. So the first I've already alluded to. Why 2 to 4 minutes of CPR before the head is elevated? Well, keep in mind, our priorities do not change because we're going to a different method of delivering CPR. Our first priority, other than scene safety, is providing high quality compressions, which generally are going to be manual. We can get manual compressions started almost instantaneously, whereas the Lucas is going to take time to set up. So first providers on scene, your priorities are scene safety, starting CPR if the patient's in arrest, and early defibrillation if they have a shock or rhythm. Don't try to be the first crew in and bring everything with you. Let the second company coming, let the extra staffing worry about things like the wedge, the gurney, whatever else you may need as part of your resuscitative efforts. This 2 to 4 minutes of CPR before we transition to heads up allows for scene stabilization, allows things to settle down, allows us to get into our rhythm, and allows arrival of additional resources. And our first crew in needs to focus on CPR and defib and let the other companies lug in the wedge, bring in the other equipment, the gurney, whatever else you need. So, be safe, get CPR started, and make sure that your compressions are effective. A second question is, what happens if the patient's in a tight place? What happens if the patient is stuck between the commode and the bathtub? Well, move the patient. You can't resuscitate that patient adequately in a tight, cramped space, whether we're talking about doing it manual compressions only, or if we're talking about manual compressions that transition to the wedge. We have to have adequate space around the patient. So it may delay some implementation for a couple of minutes until you get the patient extricated and moved to a good spot. If you can start some basic compressions where they are, and then when you get adequate staffing, you move the patient, do it. But we really have to make sure we have adequate work room in order to make this process work. So if the patient's in a tight spot, start the compressions the best you can. If you can defibrillate them, that's fine, do that. But get the patient moved out to a place where you can get around the patient and you can provide adequate resuscitative efforts. How about, can we use the gurney to elevate the head? So we have the patient, we have the wedge. Do we have to use the wedge? Well, you can use the gurney. You can use the gurney to elevate the head. There may be times where, if you're going to move the patient out of the bathroom and they're on the first floor and the gurney's already there, it might be more time effective to move the patient to the gurney and start the heads up process there. The gurney has to be readily available. You shouldn't delay this process because you want to wait for the gurney. The gurney has to be readily available for you to do this. Movement to the gurney should not delay or add significant pause to the CPR. So it's, kind of those points where you can either elevate the head and put the wedge underneath, or you can lift the patient up, put them on the gurney. Both are similar amounts of time. Well, feel free to move them to the gurney if it's readily available. But if you put them on the gurney, then you have to elevate the head to 30 degrees. You have to use the Lucas. You still have to apply the posterior pad if it's indicated. So the process of resuscitation doesn't change. You're just using a different method to elevate the head. One thing you might consider is getting an RV level, putting it on one of the sidebars of the head of the gurney, and use that to determine or verify you're at 30 degrees. I think what you're looking at here is a picture I found online. I think you could buy 2 of them for $12 on Amazon. So, it's something you could do. You probably would have to find a way to affix it to the gurney, but it is a reasonable thing to do based upon what circumstances you're facing. So you have a patient, and the patient is in arrest. You've met the time requirements, or the patient's still in arrest, like a VF arrest, and you need to move the patient. What do you do to elevate the head? Well, you really have 2 options, and it's really dealer's choice. You can use the tarp, get the patient onto the gurney and keep the wedge in place, or you could move the patient and elevate the head with the gurney. And that's kind of a smooth process. You need to figure out, maybe practice. You need to be able to move the patient to the gurney and somehow transition the wedge out from underneath the patient and have the patient rest back on the gurney. What I've got here are my suggestions, but you're the experts. You think about it, you practice it. I would elevate the head of the gurney before you move the patient, have it already up. I would remove the wedge as the patient is being placed on the gurney. So as you lift the patient up, as you're getting ready to position them on the gurney, somebody has to remove the wedge as you're laying the patient back. Somebody also needs to be specifically charged with maintaining the Lucas in good position. So you might be able to do it so the person who's moving the wedge is also stabilizing the Lucas. Again, you need to practice this transition. You need to make sure that your crew members are aware of how to do this. But it is possible to move the patient with the wedge in place, or to pull it out and keep the head elevated using the gurney. The key point is that we are going to keep the head elevated during transport. You get to pick which means you're going to use to keep the head up. I know I've heard a lot of questions about what will the EDs do when we arrive. People think about the days when we first started with the Lucas. Our crews would show up with the patient in arrest with the Lucas on, and the first thing the staff and the ED would do is turn the Lucas off and take it off. Well, I think we now have learned, and the staff have learned, how much value the Lucas has for delivering good compressions to our patients. So, I think that with education, our ED staff will continue to keep the patients' heads up. I think eventually or ultimately the decision rests with the ED physician. Once there's transfer of care, the patient is his or her responsibility. My anticipation is that they will continue the heads up. It's my understanding that all the EDs that we transport to are aware of this process. I will verify within the next week that all of the Franklin County hospitals are aware. I know my partners at East are aware. I'll verify that St. Anne's is aware. And for those of us in my group that practice at Grove City, Jackson Township and Scioto Township have been doing heads up for a year or two, so we're already used to seeing these patients come in with their head elevated. But but we are in the process of socializing with the EDs via the EMS coordinators. So this should not be as foreign a concept to the EDs on your arrival as we've had experience with in the past with the Lucas or with the some of the airway devices that we've used. So we've learned from our past errors. A couple of questions about termination of resuscitation or TOR, and these are legitimate questions that I understand, and I hopefully can answer them for you today. If I don't cover all the what ifs, feel free to drop me a note either via Basecamp or by email. But one of the questions right here is, do I really need to work the patient on scene for 30 minutes? I can see the hospital half a mile down the road. Do I need to work them for 30 minutes? Well, the answer is yes. Studies show that the likelihood of survival goes up if we work the patients on the scene. Now, it's a yes unless there are disqualifiers in place. So unsafe scene, absolutely get off scene. Nobody expects you to work a patient on scene that's unsafe. If we have a patient who's hypothermic, it's 20 degrees outside, you find somebody outside, they're hypothermic in arrest, those patients need active warming, initiate resuscitation and transport immediately. Same thing with cold water drownings, particularly drownings that are less than 60 minutes. Once you get past 60 minutes, whether it's cold water or not, the likelihood of survival is really poor. So, if the patient's drowning or a hypothermic arrest and you have reason to believe they're salvageable, transport. I think all hypothermic patients should be considered salvageable and transported. So don't wait. Another disqualifier for working on scene is refractory VF. Again, 3 standard shocks, transition to vector change, 2 more shocks. If the patient stays in VF, we transport them immediately. We don't wait for 30 minutes. Pregnant females, 20 weeks or greater gestation in arrest, we initiate resuscitation, we transport. We don't wait. So those patients are not worked for 30 minutes. Electrocutions or lightning strikes, those patients have always been an exclusion from termination in the field. If somebody is electrocuted or struck by lightning, we initiate resuscitative efforts and we transport immediately. And then there's this big, broad category of extenuating circumstances. That's what I have there because I think, we cannot protocolize common sense and good clinical judgment. There are going to be circumstances where it's not appropriate to resuscitate somebody for 30 minutes on scene, and you as a clinician need to make a determination that we need to go. So, if there is anything that you would consider extenuating circumstance, you're free to leave scene, but make sure you document in the narrative something about your thought and process. So, if you decide that, it's time to go, make sure you at least have one sentence in there that says we left because of this. And I just threw some examples in here. So, a patient who's got a GI bleeds and cardiac arrest, or has any other source of active bleeding that may have resulted in their suffering cardiac arrest, those patients should be resuscitated and transport initiated. Those patients need blood. You can work them for 30 minutes. They're not going to get any better if they bled out. So, anything related to acute blood loss, I would initiate resuscitation. I would transport. That's an example of something we can't necessarily protocolize. It's common sense. Patients who arrest in a dialysis center. That could be difficult. You can't work them well. You've got all sorts of patients around you. I would say it's extenuating circumstances. I would at least get them out of the building, if not get them off scene. And this really could be true for other public places. It could be, we joke about the food aisles at Walmart. It may not be an appropriate place to resuscitate a patient just because of the spectators and everything else that's going on. But keep in mind, you should probably spend some time resuscitating that patient on scene because there may be something you can fix. If it's a shockable rhythm, go give them your shocks, work them, try to get them back. But then if the scene is just too congested, too open to spectators, you can transport. And then if there's some strong family objection or objection to somebody there about this patient or about the patient being worked on scene, I'm okay with, common sense says, it's probably not for the patient's benefit, but we probably should just get en route, or the scene may become hostile. One of the other questions that I've heard about is, what about the patient who has ROSC? at some point during the resuscitation, and then rearrests. Well, I think if you look at our ROSC protocol, the protocol says that we're not going to terminate on scene if we had ROSC at any point in time. So if you have a patient, you're working for 10 minutes, they come back with ROSC, you're starting to do your stuff, preparing to package, and then they arrest again. I think I would resume compressions, and I would start thinking about maybe I need to move this patient down the road. Again, common sense, good clinical judgment. But there's no doubt that if the patient has had an episode of ROSC while under your care, if they rearrest, we are not going to terminate on the scene. So you can reasonably argue, I'm going to work them to get them, try to get them back, but I'm going to probably initiate transport sooner rather than waiting my full 30 minutes. So something to keep in mind, again, documenting your narrative, what your thought process is. Because if I need to look at the chart or somebody else needs to look at the chart, we like to know what your thought process is. Your medical record, your documentation could be your best friend or your worst enemy. So a sentence to indicate why you transported or didn't transport helps. So that was my quick review. I think I covered all the questions that I've heard. If you have any additional questions, feel free to let me know. You can either post your questions on Basecamp. You can talk about your questions with your EMS coordinator. But feel free to bring those questions up, because if you have a question, I'm sure there's 5 other people in the group that have the same or similar questions. And again, practice, practice, practice. I covered some of the things that I think need some additional practice, such as transitioning from the patient being resuscitated on the floor with a wedge to being resuscitated on the gurney. We've talked about how could you use the gurney to elevate the head. Have you practiced that with your crew members? Do you have a RV level or some type of leveling device to identify correct angle, so on and so on. So these are things that you need to think about and practice, because this will come with time, but it will also come with practice. It's not something you can just assume is going to happen. So that's it. That's the end of my editorial comments. Again, you could also reach me via my email, which is here. I welcome all questions, because I would like to make sure you have a good understanding of why we're doing this. Thank you.